claw hand. Classically, absent functions of lumbricals. So lumbricals, they make a L. Flexion of MCP and extension of interphalangeal joint. Claw hand is opposite. Hyperextension of the metacarpophalangeal joint and flexion of the interphalangeal joint. And when you give a splint for it, you bend the knuckles. It's called as the knuckle, that is MCP joints, knuckle bender splint. Can be used for ulnar claw hand, median claw hand, combined ulnar and median claw hand. If you have to choose between ulnar and median claw hand, answer ulnar claw hand. So this is the knuckle bender splint. The most common nerve which is involved in the human body is radial nerve. Radial nerve, most common cause is a fracture shaft of humerus. So when I look at the level at which it can be involved, it comes from the brachial plexus, goes around the spiral groove, at the lower 1/3 level, pierces the lateral intermuscular septum, comes anteriorly, divides into two parts, the posterior interosseous nerve, which goes around the head of radius, and the superficial radial nerve that gives the sensory supply to the first web space, this area. Now, this is a classical question asked. Commonest cause of radial nerve palsy, fracture shaft of humerus. Which level? And usually people answer it is the middle 1/3 in the spiral groove. But friends, the answer is lower 1/3. It's called as Holston-Lewis sign. Whatever is fixed has more chance to get damaged. At the lateral intermuscular septum, the radial nerve is fixed, so it has more chance to damage. Similarly, in the knee, medial meniscus is fixed to the capsule, more chance to damage. So remember the rule, whatever is fixed is rigid will be damaged more. Whatever is flexible will escape the injury. So lateral meniscus escapes the injury. So remember friends, is the lower 1/3 which is the commonest level for the radial nerve involvement in fractures of shaft of humerus. Remember with me, radial nerve, most common nerve to damage. Radial nerve, wrist drop. So whenever a radial nerve damage is there will be a wrist drop. Remember, radial nerve has the best prognosis of recovery amongst the damaged nerves. Usually in medical science, common things behave better. And then the sensory supply, remember the zone, the first web space. Very commonly, this question is asked to you, that a patient had a heavy bout of drinking and he slept hanging his arm by the side of the chair. When he got up in the morning, he had a wrist drop. What is it? It's called as Saturday night palsy. It is also called as honeymoon palsy because the couple, they will sleep on each other's arm, compressing the radial nerve in the spiral groove. It's also called as a squash palsy. It's the same. It's a compression which occurs in the area of spiral groove. Talking about radial nerve flow chart, I feel that every student should remember that. Let's understand what's the difference between high versus low radial nerve palsy. I will start from the bottom. Both will have sensory loss in the first web space. Both will have finger drop. You know what is finger drop? This is extension of MCP. This is drop. So loss of extension of the metacarpophalangeal joint is finger drop. Both will have wrist drop. So high and low radial nerve palsy, all the three Clinical features are same, ditto, identical. What is difference? The difference is theoretical. In high radial nerve palsy, brachioradialis muscle is paralyzed. So, there is not much to choose between the two. But then, the pure motor branch of the radial nerve, the posterior introitius nerve, which goes around the head of radius, will cause a finger drop. And then the sensory branch, called as the superficial radial nerve, will cause a sensory loss, and sometimes this nerve supplies the wrist extensor called extensor carpi radialis brevis that might be involved. So this flow chart should be imbibed in your brain, very, very important. Let me ask you one question. A patient had an accident. He was admitted to a hospital. A tiger or an intern examined him. There was clinically a wrist drop, but patient had no sensory loss. Where was the nerve damaged? Upper end humerus, the spiral groove, the head of radius, behind the medial epicondyle of humerus. Now let's understand what actually is the examiner talking to you about. When I look at the upper end humerus around the axilla, axillary nerve, presentation is more of radial nerve, question is out. Second is the spiral groove, radial nerve, we can think about it. Third, head of radius, posterior introitius nerve, pure motor symptoms, we can think about it. Fourth, behind the medial epicondyle, the ulnar nerve, it's again out. We are left with two options. One, spiral groove. Second, posterior introitius nerve, head of radius. Now, it's a trick question. Patient has a wrist drop, but no sensory loss. And a student, if he is not careful, will pick up posterior introitius nerve. But remember friends, posterior introitius nerve will only cause finger drop. Patient has wrist drop, but he does not have a sensory loss. This is possible. So the answer is spiral groove. Why is it possible? Because nerve injuries, it's not necessary, will involve all the components of the nerve. For example, the motor component is involved, but there can be a sensory sparing, causing only wrist drop, but no sensory loss. Another example, many times hip dislocation involves the sciatic nerve, but patient presents with common peroneal nerve symptoms only with a foot drop. Why? Because the CPN fibers are peripherally located in the sciatic nerve. The tibial component is central. With the pressure on the sciatic nerve, it's only the peripheral fibers which are damaged. Also, common peroneal nerve fibers are more sensitive to pressure. Hence, the nerve damage is sciatic, but presentation is of common peroneal nerve. So, when a nerve has more than one component, like sciatic has CPN and tibial nerve component, one can be involved. Radial nerve, motor and a minor sensory component, motor can be involved. Hence, it's a good question. Next, if a patient has a wrist drop, the splint given is cock-up splint, extension of the fingers and the wrist. This is the number one asked splint in entrance exams. Cock-up splint, radial nerve palsies. Now, when a radial nerve palsy is there, the first thing is wait and watch. If it doesn't recover, you will do NCV and EMG. If the EMG is not showing you signs of recovery, right, you will explore the nerve. You will explore the nerve and then you will again do wait and watch. But somehow the nerve does not recover. Then you have something called as the tendon transfer. What is tendon transfer? Taking the tendons of the intact nerve and transferring them to the damaged nerve. Example, the tendons of the ulnar and median nerve will be transferred to the tendons of radial nerve. This is called as modified Jones transfer, which is one of the commonest transfer done for a nerve palsy. Modified Jones is after the name of great Sir Robert Jones, the nephew of Sir Thomas. Jones transfer talks about pronator teres transferred to the wrist extensors. So we are trying to handle the wrist drop. Flexor carpi ulnaris transferred to the finger extensors. We are trying to take care of the finger drop. And flexor carpi radialis transferred to the thumb because the thumb movement need to come back. So we are taking care of wrist drop, finger drop and the thumb, the three important things that radial nerve control. We are not worried about the sensory supply because radial nerve is a predominant motor nerve. This you must remember. The first point is the number one asked question. If you have a nerve damage, remember this basic. Open, operate. Closed, apply a splint, wait and watch. Radial nerve, coccus splint. Ulnar and median nerve, knuckle vendor splint. If after wait and watch, it's a neuropraxia, there will be 100% recovery, and if it does not recover, get an EMG, which is the best predictor for a nerve recovery. Remember that. Good prognostic factors for a nerve injury. Growing age, good repair, pure motor or pure sensory nerve, distal lesion. But usually they don't ask you this. Neuropraxia. This has 100% recovery. Question asked. Early repair, radial nerve, best prognosis. Question asked. Maintain vascularity and end-to-end repair. Remember, end-to-end means you cut the ends and you're able to repair. If sometimes you put a nerve graft, the commonest nerve graft that you put in human body is sural nerve, and when you use it, the results are poorer as compared to end-to-end repair. Brachial plexus palsy. It's made by the nerve roots C5, C6, C7, C8 and T1. The commonest brachial plexus palsy is involvement of C5 and C6 nerve roots, the Erb's point, and the patient will present with policeman tip deformity or a waiter's tip deformity. This is a spot diagnosis. Now, what are the movements which are lost in Erb's palsy? You have loss of flexion of elbow, abduction of shoulder. These two movements are the most important movements of the upper limb. Your hand or upper limb has a function of taking care of the face, eating and protecting the face. For all of them, you need a functional hand. You need elbow flexion, shoulder abduction, so your hand can reach your face. It's very important. So flexion of elbow, abduction of shoulder. These are two movements that you must try to get back if a patient of Erb's palsy has the loss of them. Then the third is external rotation of shoulder and supination of forearm. People do think supination is very important, but it's not. Remember, pronation is very important because most of the works in today's world that you do are in pronation. And then you have something called as Klumpke's palsy, which involves the C8 and T1 nerve roots, the lower palsy. Erb's palsy, C5, C6. Erb's is more common. Erb's palsy, waiter tip deformity, which I just described. Klumpke's palsy, patient will have claw hand. And remember, Erb's has better prognosis because I told you, common things behave better. This is something that you should imbibe in your heart. Remember, sometimes you need tendons for transfers of graft. For example, most common tendon used is palmaris longus, where you have to do a small area graft like hand to fingertip, and the second is plantaris for longer transfer like forearm to the fingertip. So most common nerve used as a graft, sural. Most common tendon is palmaris longus. Most common nerve for biopsy is sural. Most common muscle for a biopsy is vastus lateralis. Then remember, if a person is lying down lateral, a superficial nerve around the knee, common peroneal nerve around the neck of fibula is at risk, and if it is involved, patient will have a foot drop. Compression neuropathy. It is compression of a nerve in a closed space. When the nerve is compressed in a closed space, you must think about the classical carpal tunnel syndrome, the most common compression neuropathy in human body, median nerve. Majority of the questions are asked on this only. Carpal tunnel syndrome, the median nerve involvement, is usually idiopathic, but they can give you a history of pregnancy, hypothyroidism, arthritis, hyperparathyroidism, or fracture Colles. It's more common in females. If you do a reverse namaskar, this is called as Fallon's test. If you maintain this position, patient will have sensory presentation in the distribution of the median nerve. So lateral 3.5 fingers, numbness will be there. You can carefully note patient might have wasting of the thenar eminence also. Then if you do a straight namaskar, this is called as reverse Fallon's test. You can do a Tinel sign also, but the direct compression of the median nerve around the area of the carpal tunnel is the most specific test for carpal tunnel syndrome, but the best is combination of various tests, Fallon's, direct compression, Tinel's test. But usually they ask you the direct compression test or the Durkin's test. Then you have other nerve palsies also. For example, when you look at the nerve palsy around the shoulder, compression neuropathy, it's thoracic outlet syndrome, where C8 and T1 nerve roots are involved. If you have to choose the one, in NB exam they ask you this, T1 nerve root is involved. Around the elbow, you have behind the medial epicondyle, the cubital tunnel syndrome, ulnar nerve. You have around the elbow, the median nerve compression, pronator syndrome. And here, superficial radial nerve involvement called as chiralgia paresthetica. Around the wrist, you have involvement of carpal tunnel syndrome, the median nerve, or around the wrist, Guyon's canal, ulnar nerve. Remember friends, Guyon's has a U in the spelling, ulnar nerve. Cubital has a U in the spelling, ulnar nerve. Then in the lower limb, one of the classical ones that you should remember, meralgia paresthetica, which involves the lateral cutaneous nerve of thigh. Around the hip joint, piriformis syndrome involving the sciatic nerve. Around the foot, there can be tarsal tunnel syndrome involving the posterior tibial nerve. You can have the interdigital nerve involvement in the foot, Morton's metatarsalgia. These are the different ones. After carpal tunnel syndrome, what the examiners are loving nowadays is thoracic outlet syndrome, where they ask you these tests, the Adson's test, the Wright's test, and Roos test. The principle is same. In the distribution of C8 and T1 nerve roots, you will have numbness, and importantly, there will be absent radial artery which you can palpate. Now, you can do the extension and abduction of the upper limb and ask the patient to tilt the neck. This narrows down the thoracic outlet syndrome around the proximal part of the neck and the shoulder girdle, causing this appearance of the radial artery, Adson's test. Or you can ask the patient to alternatively open and close and make the fist where your limb is abducted, extremited, and patient will start feeling the numbness after about few seconds or minutes. This is called as Roos test, and this video featured in AIMS 2019. Or you can do hyperabduction, where disappearance of the radial artery will occur, called as a Wright's test. All three are for thoracic outlet syndrome. Whenever we have compression neuropathies, their treatment is, I've given a name, Plan A. Plan A means do not do the provocative things, give rest and give anti-inflammatory. If no relief, local steroids. If no relief, surgery. This Plan A is the name we have given. It's not a standard textbook name. But this Plan A, where you give a conservative trial, local steroid, not oral, and then surgery, can be used at multiple places. Another video that featured in AIIMS exam was Allen's test. Allen's test talks about the patency of the radial artery and the ulnar artery in profusely supplying the hand. What do you do here? You ask a patient to make a fist. You have squeezed out the blood. Now, with your thumb, press the area of the radial artery, and with the fingers, press the area of the ulnar artery. When you do this, and you open the fist, right, you can squeeze out the blood, and it appears pale. Now what I have to see, is my radial artery palpable, or is my radial circulation profuse or not? So I will open the thumb area, my thumb on the right hand will release it, and see, does the entire hand turn pink or not? If yes, it means the circulation from the radial artery is proper. So when I do that, my hand will turn pink, you can see that. It means my radial artery is very good in circulation, and I can go and cannulate my ulnar artery. Now what I do is, again compress it, make multiple time fist, and when I do that, I press both the areas. Now I have a pale hand. Now I'll release the ulnar circulation, maintaining the radial compression. Is the ulnar artery patent? If yes, it means I can take the samples from the radial artery or do radial artery cannulation. If there is a problem in either of them, then the hand will not be profusely circulated. It means I can't do the cannulation or sampling from the arteries on either side. This is the Allen's test, whose video came as a short GIF in November 2019 AIIMS exam. I have already told you the Plan A for compression neuropathies. Compression neuropathy or entrapment syndrome talks about nerve compression. Sometimes in the exam they ask you popliteal artery entrapment syndrome. It's the compression behind the medial head of gastrocnemius. Patient will do exercise and there will be numbness or claudication in the lower limb. There will be decreased pulses on the ankle flexion.